Now our next topic is how can we use different induction techniques in everyday practice by Dr. Ankit Desai. I invite him for the same.
So my next topic is how can we use different induction techniques in everyday practice. This is my disclaimer. All permissions necessary for shooting these videos and using it for academic purposes have been taken. So the lecture highlights, mainly it consists of inhalational induction techniques. IV induction techniques everyone is aware of. That is what you use routinely. My stress in this lecture is on inhalational induction technique, which is different for pediatric anesthesia. So where do you use inhalational induction techniques? Inhalational induction techniques are preferred when you have a child with multiple procedures, a child with needle phobia. He simply would not allow you to take an IV line. In that you will have to do an inhalational induction and take an IV line after induction of anesthesia. Now child with difficult airways, this is one scenario where we prefer to use inhalational inductions. Even if the child has an IV line, still if you use sevoflurane for induction, you always remain in control. Anytime if you lose the airway, you can always shut off the sevoflurane and you can have an awake child. So this is where you would prefer an inhalational technique. Child with difficult intravenous access, many times you have a child who is in the hospital for say a month or so, all IV lines fired, you can't see an IV line, or you may be seeing just one IV line and you want to be sure that you want to take that IV line, then you would do an inhalational induction and then take an IV line rather than struggling with the child and firing that one vein that you have, and after multiple failed cannulation attempts. Now where is intravenous induction preferred? Intravenous induction would obviously preferred for rapid sequence inductions. Any case with rapid sequence induction, you would do an intravenous induction. Then high risk of malignant thermia, where drugs like halothane, sevoflurane would be contraindicated. Here you would like to do an intravenous induction. A child who has a fear of mask, you would not take except the mask. There sometimes you have adolescents, they don't like to keep masks. They allow an IV line. So there you can do an intravenous induction. Then mentally challenged children, they can be both ways. They can you may have to do an inhalational induction or an intravenous induction. Then child who enters an OT with an IV line, you would obviously prefer to do an intravenous induction. And child who chooses to get an IV line, there are many children you would ask them what do you prefer, and they would say they prefer to take an IV line. So in such scenarios you would like to do an intravenous induction. Now only thing I want to stress in intravenous induction before I go on to inhalational induction here is, remember that the volume of distribution in children is very, very high. So the dose of anesthesia at induction required is always higher. Many times I have seen that people say that patients are going into laryngospasms. It is only because you keep the child light. If the patient is in deep plane of anesthesia, you don't get any kind of spasms. The volume of distribution in children is very, very high. So the dose of propofol is not around say 2 milligram per kg. It can be as high as 4 to 5 milligram per kg. So please remember that the volume of distribution is high. Also remember that since the volume of distribution is high, they take a longer time to come out of anesthesia. So if you have short procedures, then they may take a slightly longer time to come out of anesthesia, and this is especially true for very young children. In say adolescents, it is the same as say adults. So it depends on the age of the child. Now this is one technique that we would be discussing. It is called as VIMA. VIMA is volatile induction and maintenance of anesthesia. So the only anesthesia that you are using is volatile induction, which I would be showing in the video form. So basically there are three forms of induction. One is a tidal volume induction, which we commonly do. So second form is a vital capacity induction or a single breath induction, which is very much popularized with the advent of sevoflurane because it is more cardio stable and the risk of arrhythmias are much lesser as compared to say halothane. And the third and the most common that we use is overpressure induction. Now I'll be dealing with each one of those inductions. Now tidal volume induction is your conventional induction. So what we are doing is you start fresh gas flows, air oxygen or nitrous oxide oxygen at equal flow, say 2 liters or 3 liters, whatever you are comfortable. Remember at induction there are no low flows, that is always high flows. Low flows are meant for maintenance of anesthesia. There are no low flows in induction of anesthesia. So the fresh gas flow is constant. You start at a fixed concentration of sevoflurane, say you start at say 1.5% and you gradually increase every 3-4 breaths to 8% of sevoflurane. So that is your traditional tidal volume induction. Now second is is the vital capacity induction or a single breath induction, which is so called single breath induction. Many times it is not a single breath induction. So here the necessities are a system which is filled with 8% sevoflurane, that is your circuits, your bag, everything should be filled or prepared with 8% sevoflurane. You start at a constant fresh gas flow, say 2 or 3 liters of air, oxygen or nitrous oxide, and patient has to take a vital capacity breath. Now what is a vital capacity breath? Vital capacity breath is full inspiration or full exhalation and full inspiration, and you hold the breath in full inspiration. That is your vital capacity breath. So full expiration to full inspiration, and you have to hold your breath. Now many times children will not cooperate for this. This may be possible only in say adolescents or in a very cooperative child. So essentially many times you are not doing a vital capacity induction. What you would be doing is called as an overpressure induction. So here the induction is the same. Here you start at 8% sevoflurane. Even in single breath induction you start directly at 8% sevoflurane. In your tidal volume induction you start at a lower concentration. You start at 1.5, gradually increase to 8%. In your vital capacity induction you start at 8% and child has to take your vital capacity breath. But in overpressure induction, the difference between overpressure and vital capacity induction is the child is just taking rapid breaths or deep breaths. He is not taking a vital capacity breath, but he is taking not tidal volume breaths but deep breaths. So overpressure induction is a faster induction than your tidal volume induction, and overpressure induction starts directly at 8% sevoflurane. It does not start with 1.5% sevoflurane, and it keeps taking deep breaths. So the result is a rapid induction. So this can be used for rapid induction in say very uncooperative children. You need to put him off to sleep very quickly, or you have a parental presence inside. Parents can be present inside the operation theatre. You can directly put 8% sevoflurane, and within say 4 or 5 breaths he goes off to sleep. At least he goes off to sleep. He may not be in a deep plane of anesthesia, but he will go off to sleep. So remember, I stress this in each and every lecture that I take. There is a difference between a skilled pediatric anesthesiologist and an occasional pediatric anesthesiologist. If you are an occasional pediatric anesthesiologist not used to managing the pediatric airway, please don't use inhalational induction techniques without an IV line. Always take an IV line and do inhalational induction if you want. But if you are a skilled pediatric anesthesiologist, you are practicing it daily, then you can use inhalational induction before taking an IV line, because you should be able to manage a laryngospasm without an IV line. So if you are a skilled pediatric anesthesiologist, then inhalational induction techniques with the proper pre-medication is the way to go. So if you are not if you are an occasional pediatric anesthesiologist, the ideal way is to go is to learn from someone who is a skilled pediatric anesthesiologist. You can always come to us and learn from us. So this is the first slide. This is a slide showing, it's not playing over here, I think it's playing over there. So this is a small child. Do we have a collar mic? Okay, I can take it this way. So you can just see how we are doing an inhalational induction. This is a tidal volume induction. I just want you to observe how the child is breathing. This is a JR circuit. The flows are around 2 liters per minute. This is, we are using oxygen nitrous over here. The air was not available in that particular nursing home. So now this is the stage of light plane of anesthesia. If you take an IV line over here, in this stage you would definitely have a laryngospasm. So this is not the time to take IV line. So you want the child to be deep. You should not be in a hurry. Let the child go under anesthesia. Let the child go in proper deep planes of anesthesia before you start pricking him. So just wait. You are gradually increasing. Now I am gradually increasing the concentration. We have started at 1.5. This is at a constant flow. Gradually we are increasing to 8% sevoflurane, and now you can see the breathing is changing. So your goal is that the breathing should be same as what it was pre-op. Like in an awake child, how he is taking a tidal volume breath, he should reach that stage before you start pricking the child. So now you can see the breathing is improving now. So when we are alone, what we do is we have our technique of tying the mask, which I will be showing in the next video. So we tie the mask in one like a harness. The mask that we tie over the face, we keep it below the head of the patient, like it is kept over here. If you can appreciate that, it is tied to the mask. So this is how like if you are alone and if you don't have help, you would be able to manage everything single-handedly. So once the patient is deep enough, we tie the mask and then we proceed to take an IV line. Now if you can appreciate, the breathing is very much regular. You can even make the child apneic. It doesn't matter. You can ventilate the child. Apnea is any day better than a laryngospasm. You are anesthesiologist. You can always ventilate the child. And with sevoflurane, they don't go into cardiac toxicity and all. You can always reduce the sevoflurane, and the heart rate will come up if at all you have a bradycardia. So now this is the stage where you can start taking an IV line. So now this is a mentally challenged child. This is a slightly mentally challenged child. I had allowed the parent to come inside the operation theatre. She also had a URTI. Voice one turn. Mic चालू कर. So this is a mentally challenged child. She was appropriately pre-medicated. The only difference between the first induction and the second induction is here we are using a closed circuit for tidal volume induction. So here we start at a constant flow. The flow is around 2 to 3 liters per minute of air oxygen. And you can see how she is breathing. This is happening because she had a recent URTI. So in children who have a recent URTI and you have not taken an IV line, it is very important that you manage the plane of anesthesia properly. Laryngospasm is a very, very preventable complication in the hands of a skilled pediatric anesthesiologist. Laryngospasm is a preventable thing. Laryngospasm is better prevented than treated. Always remember that. So instead of proceeding with the IV line in a light plane of anesthesia, what we would do is we would allow the child to go in proper deep planes of anesthesia. Now you can see the breathing has improved. This video is actually a fast forwarded video. Now you can see how we tie a mask. So this is how the mask is tied, and I am single-handedly managing the airway as well as I am able to take the IV line. These videos are more for private practitioners. If you are alone in private practice without any help, these are not for institutions. It's always better to have 2 anesthesiologists for any particular case. So now the patient is deep under anesthesia, and you are pricking the child only when the patient is under deep plane of anesthesia. So now we have a secure IV line, and you can proceed with the anesthesia. Now whether you want to proceed with the mask, LMA or endotracheal tube, it entirely depends on your wish and your comfort. If you are comfortable with an LMA for a superficial surgery, it is your comfort level. We are comfortable with mask, as madam had demonstrated, so we would do the case under mask and some sort of regional anesthesia. If you are comfortable with LMAs or if you are comfortable with endotracheal tube, you can proceed with that. This is just to show how you can do an inhalational induction and then take an IV line. So as I said, the planes of anesthesia that are helpful in children are, one is the awake plane and deep plane. These are our friends. Light plane is our NEP. Never ever do anything or any stimulation in light plane of anesthesia. Another form of anesthesia which madam mentioned was sedation. So what we routinely do is superficial surgeries under mask anesthesia with a properly acting regional anesthesia. You can just reduce the anesthesia to a sedation level. So essentially what you would be doing is doing the case under sedation with regional anesthesia or regional anesthesia with sedation. There's a difference between, say, general anesthesia with regional anesthesia and sedation with regional anesthesia. So essentially what we do with using mask techniques is, after the regional starts acting, the case would be done in the regional anesthesia, and you just have to keep the child sedated or immobilized. So sedation is a stage which is helpful for us, and it helps to reduce the total dose of anesthesia that we use. So that is how we do superficial surgeries in private practice. So now this is a small child. This was posted for a herniatomy. This is a neonatal hernia, preterm hernia. The child came inside with an IV line. I found that the IV line was outside. It had extravasited. So now the only option we have, as I said, we don't pre-medicate this child. So, and he was in the NICU for around 2 months. So none of the IV lines were visible. So the only way to go is inhalational induction and then take an IV line. So his IV line was out. This is another example of an tidal volume induction with a closed circuit. So we start at around 2 to 3 liters per minute. Here we had air oxygen available. So the previous cases were oxygen and nitrous oxide. Remember, with air oxygen it takes a longer time to achieve an adequate depth of anesthesia. With nitrous oxide it is always faster. But air has its own advantages. We will not go into differences between air and nitrous oxide. So again we wait for the child's breathing to improve. So now you can see the breathing. This is the light plane of anesthesia. You would not pick the child in this plane of anesthesia. Let the child go under anesthesia properly, or let him become apneic, or let the breathing become regular. Only then you start taking an IV line. Again we tie the mask and we take the IV line. This is for a very small child. See, no, this is a fast forwarded video. Generally it takes around 2.5 minutes for the child to go properly under anesthesia. Now the child has become apneic actually, and then we proceed with taking the IV line. This is another child who is around say 3-year-old child. This is with the tablet based interactive distraction. I had allowed the parent to come inside. The parent was holding the mobile, and she was also pre-medicated with midazolam. So again we are doing another example of tidal volume induction. So you can see how well the sedation and the tablet based or whatever mobile based interactive distraction works. Now this is a child who had come with an IV line. Many times in premature babies you don't like to give propofol because it causes a lot of bradycardia and it causes a lot of hypotension, especially those which are in sepsis. So another way of inducing the child is giving sevoflurane and scoline using a rapid sequence induction kind of technique with the use of sevoflurane. So here what we are doing is we are doing a vital capacity induction or an overpressure induction. Of course you must always have an RT in place. The RT should be aspirated. If you had observed that I had aspirated the RT previously, you do a very rapid induction, just 3-4 breaths of induction, give immediate scoline, you ventilate once or twice and you put the tube. So if you don't want to use propofol, then this is another technique with the use of sevoflurane where you can do a kind of rapid sequence induction without the use of IV inhalational agents, IV induction agents. You can use inhalational induction as a technique for rapid sequence induction. So now coming to your overpressure induction. Now before you start overpressure induction, you have to prime the circuit. So generally what we do is we apply some sort of a glove or something to the circuit. You always use closed circuits for overpressure induction. You start the fresh gas flow at around 2 liters per minute. You increase the sevoflurane directly to 8%, and if you can see, you have to empty the bag at least twice or thrice before you put the mask on the child's face. This is because you want to prime the entire circuit. Generally this takes around 30 to 45 seconds before the entire circuit gets primed. If you have a volume or a gas analyzer, you have to see that the level should be at least 7% sevoflurane before you put the mask. So now you have put the mask. This child is very small. He is a pre-medicated child. He will not cooperate for a vital capacity here, but he can take deep breaths. So he is taking deep breaths, and within say 4-5 breaths he goes under anesthesia. So you can see how fast he gets induced. So this was the difference between your tidal volume induction and this is your overpressure induction. Immediately they go under anesthesia. This is a slightly bigger child, again for a GI scopy. This is what I called a VIMA technique. VIMA technique is your volatile induction and maintenance anesthesia. So this is posted for a gastroscopy. Only for a scopy, there is no intervention to be planned. So the only anesthesia that you required is sevoflurane. You don't need any opioids, you don't need any glycopyrrolate. So what we are doing is, we are again doing an overpressure induction. We take the child deep under sevoflurane, and sevoflurane is the only anesthetic agent that is used. We are using nothing else. Only thing we will use is an antiemetic to prevent PONV. So only with sevoflurane you are taking the child under anesthesia, you are maintaining the anesthesia only with sevoflurane. But remember, this takes at least 3 to 4 minutes to reach that plane of anesthesia. It takes at least 3 to 4 minutes for a deep plane to be achieved. So we are inducing and we are intubating in a very deep plane only with sevoflurane. This is a technique that we commonly employ for all our bronchoscopies. Bronchoscopy surgeons do not like relaxants many times. So the only technique that we use is volatile induction and maintenance. So take the child very, very deep with sevoflurane, make them apneic. Once they are apneic, just hand over the child to the surgeon. He will insert the scope. As soon as the scope is inserted, you will see that the child starts breathing because of the stimulation, and he is able to maintain your spontaneous respiration. So the spontaneous, only sevoflurane can be used for bronchoscopies. Maybe in bronchoscopies we give a bit of, say, 1 milligram per kg of ketamine and some glycopyrrolate, but this is a gastroscopy where I have used only sevoflurane for the entire procedure. You have a child who is completely awake at the end of the procedure. I am not saying that you should practice this. I am just saying that you should know that there is another technique like VIMA, and you should have it in your armamentarium besides your IV induction drugs. There is nothing wrong in doing an IV induction for a gastroscopy, but you should know this technique. This is a different technique. So again, if you see, we are waiting for the child to go properly under anesthesia, and it takes a very long time for him to go under anesthesia. And we are doing this at 8% sevoflurane right from the beginning. This is again a forwarded video, fast forwarded video. This is not at normal speed. This is at 2 times speed. So I have ventilated him for at least 3 to 4 minutes. I have given him nothing, and I have intubated the child only under sevoflurane without the need for any relaxants. Once the tube is inside, you can always maintain him even with an AT tube on spontaneous respiration. But you should always have an ATCO2 and make sure that the ATCO2 does not rise. You should always monitor ATCO2. So the difference between high initial concentration versus low initial concentration, this is a meta-analysis which has shown that with overpressure induction, the induction is at least 24 to 82 seconds faster than your tidal volume induction, and respiratory complication rate except apnea is the same. So the incidence of laryngospasm or bronchospasm is the same with your tidal volume induction and your rapid sequence and your overpressure and vital capacity induction. So another study, this is an Indian study where they compared incremental induction versus overpressure induction. They also found similar, and they found that the cost savings was actually higher with your overpressure induction, because with tidal volume induction, at induction the amount of sevoflurane required is far higher. Thank you.
Thank you, sir, for sharing your practical views and tips. Any questions?
Hello. Hello, sir. Can we use sevoflurane with Goldman vaporizer if specific vaporizer is not available?
No. I think isoflurane and halothane can be used with Goldman vaporizer. They say that isoflurane is better suited for Goldman vaporizers, although Goldman vaporizers were meant for halothane. But isoflurane can be used because the physical characteristics are the same, or they are actually better with isoflurane. But with sevoflurane, you cannot use Goldman.
My induction technique is 1 liter oxygen and 8% sevoflurane. Where does it fit in this?
As I said, sir, for induction you need higher flows because it takes some time for the sevoflurane concentration to build up. Even in the body, if you are using very low flows, say at 1 liter or so, it takes a longer time for you to induce the child. So initially you start with high flows. Gradually over say 3-4 minutes you can start reducing the flow. So generally we start with say 2 liters. Gradually we reduce in say 5 minutes to 1.5 and gradually we come down to 1 flow, or even if you have a good workstation then you can come down to 0.5.
By and large it is Jackson circuit.
Sorry sir?
It is Jackson circuit. By and large,
so at least 2 liters for induction you require.
1 liter oxygen and 8% sevoflurane. That gives good induction characteristics.
Just takes a bit longer. It will definitely help you in inducing the child.
Excuse me. But when you
IV line secured, then
Yeah. So as I discussed in the slide, I had shown you in specific scenarios, if you have an IV line secured, say you have a syndromic child, a child with a Pierre-Robin syndrome or a Treacher-Collins syndrome. In such a scenario, I would always have an IV line secured before I start with an inhalational induction. But even with a secure IV line, I would go for an inhalational induction because I would like to have a better control. With propofol, they take time to come out. With sevoflurane, if at any stage you feel that you are losing the airway, you can shut off the sevoflurane and the child would be awake. So in such cases with say difficult airways, or if the child is coming up with for a bronchoscopy or something, in such scenarios I would always have an IV line before induction and I would still go for an inhalational induction. Otherwise there is nothing wrong, you can go do with both. Both are good techniques and both are equally useful.
thank you.
Hello. Sir, nice presentation.
Thank
If during induction some laryngospasm, bronchospasm, then what will be your practice to come with that? With only inhalation induction, no IV line.
Yeah. So that is a very good question. Actually, I wanted to discuss that. So if you face such a scenario, first thing, as I said, prevention is always better than cure. So how you induce the patient always determines whether a child would have laryngospasm or not. In a child with URTI, if you are using a Jackson-Rees circuit, always remember that you always maintain CPAP when you are inducing the child. If you maintain CPAP, you will not have laryngospasm in most of the time. So CPAP, in most books they say they use it as a treatment of laryngospasm. I would say it works as a measure to prevent laryngospasm. So if you are using a say closed circuit, always keep the APL valve at a position of say 5 to 10 centimeters of water. That would help in preventing your laryngospasm. Now despite all measures, if you have a laryngospasm, then first and foremost thing is don't panic. Nothing will happen to the child. You just don't have to panic. Now if you are the lone anesthetist, if you don't have any other anesthetist with you, don't leave the airway. Don't go for attempting an IV line or something. Just keep holding the airway, increase the oxygen to 100% oxygen, keep maintaining CPAP. Most of the time with CPAP the laryngospasm would be relieved. Other measures that can be used is Larson's maneuver. If you don't have a if it is not getting relieved with only CPAP, then you can use this on the notch. You can just give some pressure. Larson's maneuver works very well. Books describe that gentle chest compressions also works very well, and it is in fact more effective than Larson's maneuver. So these are the maneuvers that you can use. Other thing, if you have say a pediatric surgeon with you or someone who is capable of taking an IV line, then while you are holding the airway, ask him or her to take an IV line so that you can push in some propofol or deepen the anesthesia with propofol. You cannot deepen the anesthesia in a child with laryngospasm with say sevoflurane because it will not work. So you will need an IV line to give an IV induction agent. So with someone can attempt an IV line and they can take propofol and scoline. Worst come worst, if it is still not getting relieved, always remember that hypoxia cures laryngospasm. Saturation which is less than 50%, the child may become bradycardic for a momentary second, but once he becomes bradycardic, you just give one breath of 100% O2 and the pulse rate will come up. So don't panic. Even if you have a laryngospasm, it will cure on its own because like I would like to ask a question like is laryngospasm seen in awake patients? Can I have a laryngospasm now? Anyone can answer that. So laryngospas is seen even in awake patients. Laryngospas is a primitive protective reflex. It is there to prevent your aspirations. So even when you are vomiting, you have a laryngospasm. So laryngospasm has two components. It has a cerebral control and it has a control at the level of the hypothalamus. So when you are giving anesthesia, you lose your cerebral control. So what happens in an awake patient is when you have a laryngospasm, the cerebral control takes over and the laryngospasm gets relieved on its own. So but under anesthesia this cerebral control is lost. So laryngospasm does not get relieved on its own till the patient becomes hypoxic or hypercarbic. So hypoxia and hypercarbia actually cures the laryngospasm, and just with one breath of oxygen 100% O2 the pulse rate will come up. So first and foremost thing is never ever panic, and there is most of the time 99.99% of the times you don't have to intubate the patient. Just keep holding the mask, give CPAP, keep on giving CPAP, maybe give a Larson's maneuver, and with one or two breaths he may come up. Another maneuver which has been described, which I have never used, is sublingual or intramuscular scoline to relieve the laryngospasm, but I have never used it. It is described in books. They say that when you give scoline in the buccal mucosa, then since the flow is higher, and especially when you have a hypoxic patient with say bradycardia or something, a vascular area would absorb it much faster. So buccal scoline may also help. I hope that answers your question. So as I said, it depends on the stage of anesthesia. Either you can make the patient awake or you can take the patient deep, nothing in between. So if you have a patient who is say towards the lighter plane of anesthesia, you can shut off the sevoflurane and just give propofol, because sevoflurane would anyways not act, and you can start the sevoflurane once the laryngospasm is relieved.
Yes, to the contrary to the belief, don't lighten the patient. Go ahead, in fact, deepening the patient if you can. If you even see laryngospasm doesn't come suddenly, it gives you an indication that the larynx is about to go into spasm, because the back movements will reduce, or there would be some kind of a jerky movement in the child. He will try and breathe. One or two breaths is going to tell you that the spasm is going to set in. At that time, please don't off the nitrous, but don't reduce the inhalationals.
But deepen with IV agents.
Yes, if you have an IV, deepen with IV agents, because you have a lifeline. There is one beautiful editorial written by Robert Walker with which port in the storm. It's in pediatric anesthesia. So I think you all should read it. It's very interesting. And why I remember it so vividly, because it was first published on 13th of July, which happens to be my birthday. All right. So please do go read this article. Which port in a storm? Very beautifully written. I mean, it's exactly what Ankit has said.
Another point I want to emphasize, it is not related to induction or inhalation induction. If you observed all the videos, you must have seen that in all patients before induction, Ankit has applied ECG leads. Our seniors like Vaishnav sir and Dipti madam always emphasize that always apply all possible monitors when you are inducing the patient. Otherwise, sometimes your pulse oximeter get displaced and you won't have any monitoring when your patient is in bronchospasm or laryngospasm. So always apply all possible monitors while inducing the patient.